It's good to hear from you this morning. Another beautiful Wednesday morning.
Midweek. It's midweek.
I know what you did there. Well, good morning, Nigerians, and welcome to FCT Brief. We're reaching you live from our Abuja studio. Today, we turn our attention to a pressing issue in Nigeria's public health sector: growing challenges in delivery of immunization services and access to basic healthcare, especially in rural and underserved communities. While vaccines remain one of the most effective tools for preventing disease, gaps in supply, logistics, outreach are undermining progress. Some stakeholders say in most primary healthcare centers in rural communities, mothers line up early hoping to get their children vaccinated. But many go home disappointed because either the vaccines are out of stock or the healthcare workers are overwhelmed.
This story echoes across many parts of Nigeria. While national immunization campaigns continue, healthcare delivery faces major setbacks from vaccine distribution, bottlenecks, and cold chain failures to shortage of trained health workers. And government officials acknowledge the challenges, but say steps such as strengthening primary health care centers, providing solar-powered fridges for vaccine storage, and partnering with NGOs are being taken to address them. Experts also say unless Nigeria urgently addresses the logistical, infrastructural, and manpower deficits in its healthcare system, immunization efforts and public health at large will continue to face serious setbacks. For more on this very important area of our national life, let's bring in the Acting Executive Secretary of FCT Primary Health Care Board, Dr. Rukaya Wamako. And sitting next to her is the World Health Organization State Coordinator for the Federal Capital Territory, Dr. Kumshida Yakubu Balami. Thank you both for coming on the show this morning.
Thank you. It's good to have you in our studio.
Thank you.
Yeah, let's look at it this way. From the introduction, we learned that mothers in most primary health care, not just in FCT across the country, sometimes queue up endlessly for vaccines that are not just there, and also probably the perception of the public. Tell us, what has been your experience on the field so far?
Okay. Thank you so much, viewers, for having me. I want to say that, yes, quite okay. Women will line up in the facility to access basic health care in the primary health care facilities, including immunization. But the issue here is that we all know that there is constraint of healthcare workers due to the drainage of healthcare workers abroad and leaving the country with shortage of manpower, especially the skilled manpower in Nigeria. And FCT will not be exceptional on that. Because of that, you see that the services where we're supposed to have maybe 4 nurses or community health extension workers handling, you may end up having 1 or 2 handling, or we may end up in the entire health facility is only 1 person improvising to do all the services for the people that comes to the facility. Because of that, the people in the community has to line up, has to stay longer than necessary because manpower is not there. In terms of availability of vaccine or essential medicines, though we have shortage of essential medicines, and the vaccines are also available, not as such, but honestly speaking, the availability of this vaccine is always there because they improvise, because the immunization, the routine immunization is a one-day something that happens within the week. Each facility has a particular day they arrange for the vaccination. So they make sure that they collect the vaccine either from the state store down to the area council store, then to the service delivery point in the facility. So they rationalize the vaccines according to the days of vaccination. Some facilities will be on Monday, some on Tuesday, Wednesday, like that. So they cycle among themselves and rationalize the availability of vaccines as well as the cold chain. In terms of services, all other services rendered, especially on maternal and child health, are available in the facility. It is the manpower. The issue great issue is the manpower, availability of this
challenge,
manpower.
Dr. Wamako, I would like to ask, is accurate data. I hear that this is a big challenge as well in tracking immunization efforts. Without it, how are you able to know communities that are being left behind? And in the case that you have data, who provides this data and how do you verify the accuracy of the data that you've collected?
Usually the vaccine or routine immunization, the data is being generated in the facility by those giving the services. We have the HMIS registers there. We have the tally sheets there. As they vaccinate, they tally in and they enter into the register. And then the daily register will now feed into monthly summary form register. And then the people that the M&Es that comes to collect the data on monthly basis will now feed it into the DHIS2. This is how the sequence goes. So now, on the other hand, during the SIAs, that is during supplemental immunizations campaigns, what we do as they goes into the community, either house to house or at the fixed post or temporary fixed post, they collect this data into the tally sheet and follow the same channel into the register, and then it now goes to the DHIS2. So with this now, by the time this collation has been made and it goes into the DHIS2, the data now sometimes you see that some facilities that are doing routine immunizations or during the SIEs is not captured in the DHIS2, including private facilities. So there is need to expand that DHIS2 so that those facilities can be captured 100% and then the data goes in there. But actually, we collect the data and then we analyze and then it's been posted to DHIS2, which is the national platform for collation of data.
Okay, Dr. Bala, let me come to you, WHO person in here. Now, talking about the gaps you have noticed so far, how do you think, looking at the international best practice, that we can bridge these gaps? Especially we'll talk about the perception also. We know in the northern part of the country there is this perception also, probably because of religion and all that. How will you advise that we bridge these gaps when it comes to immunization and primary health care, which ought to be the primary responsibility of the local governments?
In addition to the limited health workforce we have, in terms of availability, two major issues or challenges we face is the first is on health infrastructure. If you look at FCT holistically, it's an ever-exploding expansion where you have many new estates that were never there before. Some are never in the plan. So those estates come out without even a health post, not to talk of a health facility. And for you to ensure vaccines reach, you need to have the adequate logistics, which involves the cold chain. So one of the strategies we deploy is the use of mobile medical outreach services, where in a particular location we have a primary health care center. The health workers there also place it on their schedule within the week to move to these new locations where people are living to provide services. We also use civilian JTFs, the military, and of course some of our security forces to support our health workers in providing immunization where there are security issues and where it's a security threat for our health workforce. We also have vaccine hesitancy and misinformation. It's a big challenge within the community. So we've achieved a lot of success through our traditional leaders, religious leaders, and our political stakeholders, where we do a lot of sensitization and awareness within the community. They also demonstrate, they use these vaccines, and then their followers follow suit. And these are some of the best practice we've recorded in FCT so far.
All right, we'll still come back to that, but that'll be right after this short break. Don't go anywhere. We still have more for you on the program. Stay with us. We'll be right back.
Life is politics. In Nigeria, almost every part of our lives is touched by the politics we play. Governance, legislative matters, the economy, security, foreign affairs, internal affairs. Have a feel as strategic plays in the political space determine how we live in Nigeria. The players, the drama. Be kept informed.
Some say learning is fun, but as a mom, I see how demanding it can be for my child. That's why I ensure he starts every day with a cup of Bonvita. Bonvita, prepare them to win every day.
We don't like to eat better. More nutritious meals, more veggies. But we want it tasty and easy too. Knorr Cubes, that's the secret. Made with real ingredients like chicken, parsley, and garlic. And enriched with iron, so your meals are better for you and more delicious too. That's the cocoa. Let's give it some accolades. Change your world by changing what's on your plate.
So why do you need Dettol 12-hour protective shield?
Why? Well, you'll come and see.
Children unknowingly share germs with one another, especially when they play.
I used to get worried when he was away from me, but not anymore.
Because you have Dettol's 12-hour protective shield?
You safe, Sabi.
Germs are everywhere, but Dettol's 12-hour protective shield shields your family every day, keeping them safe,
Healthy, happy, and successful.
Dettol, be 100% sure.
We're glad to have you back. You're still watching TVC Breakfast, and this is FCT Brief. We're still discussing immunization and vaccine coverage, and we still have two beautiful ladies with us in the studio, Dr. Balami and Dr. Wamako, helping us to dissect these issues. Now, I'd like to still stay with you, Dr. Wamako. Immunization success isn't just about, government efforts. How is partnership with international bodies like the World Health Organization also helping in improving coverage of these vaccines?
Dr. Balami.
Okay, Balami wants to answer that.
Oh, okay. Dr. Okay, Dr.
I'm
Wamako.
Dr. Wamako.
All right.
Okay. The partnership, primary health care is more or less a charity work. It's not a revenue generating system. And it suffers a lot of neglect over the years, not until recently things are coming up now with this present regime. So we cherish partnership at primary healthcare services levels system at all, both at the state, federal, as well as the local government. Now, WHO is one of our major partners in sustaining the primary healthcare system at all levels. And then we have UNICEF, we have any other partners, including our local NGOs. They come, we partner with them, they support the system. Over the years, it's been a kind of donor-driven activity or services that we are rendering with support from the government, but from the federal, the state, and then as the local government. Now there is a structure under the primary healthcare under one roof, as well as a basic healthcare provision fund. Now the new MedFull coming up. So all these come together to see that primary healthcare system is being taken care of, both at the level of infrastructure, as well as the level of manpower, as well as the services itself, the availability of essential medicines, essential equipment, as well as commodities and consumables. Without availability of all this, whatever services we want to render, there is no quality in it. We also need to have manpower, skilled manpower, trained manpower. Unless it's only this time around that we have a kind of holistic primary healthcare integrated training of healthcare workers. 120,000 primary healthcare workers across the nation were trained on integrated primary healthcare services. This is an effort by the Minister of Health, Professor Alipati, with the initiative of Renewed Hope Agenda to do such training. Because primary healthcare workers have suffered a lot of decay in terms of knowledge, because they have not been trained for quite a long time. It's only the mentorship during skeletal supervision, supportive supervision, that we go into the facility periodically to mentor them. But that massive training has really helped a lot to see that the little manpower that is available now, apart from the drainage, the ones that remain, we have them trained, and then all the services is being done. Integrated primary healthcare training means that if you meet one healthcare worker in the facility and the entire family has come, the husband, the wife, the children under 5, maybe 1 or 2, the mother-in-law, the caregiver, or maybe a house help coming with them along. All this will have services. For example, a woman that comes, she may be pregnant. She needs to be registered for antenatal care by this same single healthcare worker that is available. After registering her on antenatal, and then we'll send her for basic investigations in the laboratory, and then the mother-in-law that comes along with her, she needs to have her BP checked to see that, and then her blood sugar being checked to rule out non-communicable diseases like hypertension and diabetes in her. The husband that follows also needs his BP being checked, and then his blood sugar being checked to make sure that he is well and healthy. The 2 under 5s that comes along with her, it means the healthcare worker should be able to ask about the immunization history of those under 5s. And then maybe if there is defaulting or there is skip anywhere, she should be able to reposition them back into the routine immunization, and then give them the routine immunization that they're supposed to take at that period that they come. And then the house girl or the adolescent girl that comes along with them should be able to be vaccinated with the HPV vaccine, so that we can protect her from cancer of the cervix. So this is what it means. So a healthcare worker now, even if you are one in the facility, the issue of I'm with ANC, no, I'm with immunization, no, I'm in the laboratory, no, I'm in this, does not even arise. Once you are a community health extension worker, or you are a midwife, or you are a nurse, or you are a CHO, you are holistically trained to give services, integrated primary healthcare services. So the entire family can come into the facility and have access to entire of these services by one person present. Though it's taxing, but we are trying to see how we can acclimatize with the situation we find ourselves because of the constraint of manpower.
Definitely a huge task out there for a primary healthcare giver.
Yes, that
to
is
like
what
a
it
jack
means.
of all
Yes.
trades. Now, let me come to you, Dr. Balami. Now, talking about all these, my challenge also is that this ought to naturally be the responsibility of our various local governments. Now, we have the federal government always intervening, but providing the electricity is key. Talk of the cold chain, you need electricity, and most of our rural areas don't even are connected to the national grid. Now, can we begin to talk about solar-powered stuff in all the local governments, 774 local governments across the country? Would that be a way to encourage the healthcare providers in those rural areas to render services?
Absolutely. It's already in pilot in FCT because we have a technical working group for solarization of primary healthcare center, which WHO is providing technical assistance to that working group and is looking at reviewing all the PAC centers in FCT, those that are solarized and those that are not, and developing also the roadmap, costed advocacy to other partners also for support in terms of coverage. So for WHO specifically, we have expanded our technical assistance in FCT. We have workforce at all levels. From the settlement level, we have a workforce cadre we call the field volunteers who work hand in hand with the community to provide sensitization, demand generation for vaccines, and of course, community mobilization. Then we also have the second cadre that works at the ward level, and of course the area council, where we call the local government in other places. They are called the local government facilitators. They work hand in hand with the medical officers of health, the local government immunization officers, the cold chain officers in terms of providing logistics. And of course, at the FCT state level, we also have specialized technical experts that work with the Health Secretariat, the Public Health Department, and the FCT Primary Healthcare Board in all of the thematic areas that entails vaccine delivery, which is not just the logistics supply, but including the coordination. And of course, we support in capacity building of healthcare workers at all levels, which involves training, monitoring, and effective supportive supervision in terms of timely identification of issues, and of course, drawing the attention of the relevant stakeholders that needs to make those services or to fix those issues.
Well, let's talk about our ability to produce vaccines here at home locally. How equipped is our healthcare system to support, equipped is our healthcare system to produce vaccines locally? Have you started considering that?
That is already on the table of the Coordinating Minister of Health and Social Welfare, where he has been advocating for local manufacturing, including vaccines. And I think that is a great step in terms of leadership direction. And very soon, through the SWAP Coordination Office, I believe Nigeria will have that reality in terms of manufacturing vaccines.
Okay, Dr. Wamako, let me come back to you in this case. So far, when you go to the field, there's this perception index by a lot of people. What has been the experience like? And the other time you were talking about shortage of manpower. My worry also is we do have School of Nursing. We do have medical facilities in almost all the states, whether the federal, the state. They graduate personnel every year. Now, what are the challenges? Is it that this shortage, because we have leakages, like you said, people go abroad, greener pasture, but is it that we do not recruit as we should, or what? But
Thank you so much.
Just hold your thoughts there. We'll quickly go on a break, and when we come back, we'll dwell more on this particular issue. Please do stay with us.
Life is politics. In Nigeria, almost every